Thank you for all of you for getting up so early in the morning, probably after quite a late night. I'm going to talk about the pathogenesis of anemias. I'm no haematologist. It's not going to be a very detailed talk about very sort of detailed things about anemia. I'm going to talk about how it relates to our clinical management more of anemia rather than a haematological point of view. And I'm going to talk about what causes anemia in our patients, how we can diagnose it, and what effect it has on outcome after surgery, the different sort of classes of anemia. Other people after me are going to talk about treatment, are going to talk about management. I'm just going to talk about what causes the anemia and how that affects things. So ACTA as a society are interested in anemia because it has a large impact on our patients, or at least we believed it did from a sort of a single centre study at Papworth. So we undertook a national study last year, a coordinated ACTA study, and we looked at all adult patients undergoing cardiac surgery over a 3-year period, and we used the WHO cutoff of 120 for women and 130 for men. And we got data from nearly 20,000 patients, and the incidence of anemia across the UK in the last couple of years is a third. So 31% of patients have anemia. So I can categorically say a third of your patients coming for surgery are anemic for cardiac surgery in the UK. And that's very important data because we thought it was high, but this is actually, categorically the data. And those who are anemic have a higher logistic Euro score, so they're more at risk for surgery, and they're more likely to. They're sort of similar in terms of other demographics. And there is some variation in the country. So, for example, Papworth is this one here, number 5. We have more anemia than anywhere else in the country. So I don't know why it is in Cambridge that we have more anemia, and that's an interesting fact. But you can see that the variation is between sort of 20% in some parts of the country and 45% in others. So I'm not exactly sure why there is such a variation around the UK. And this study included Scotland, Northern Ireland, London, Manchester, Wales, and there is quite a lot of variation, and that's important from a research point of view because you need to know what the background is when you're designing a trial and when you're looking at outcomes from a trial, and you need to know the same for transfusion if that's one of the outcomes you're looking at. So we're hoping as a society at ACTA that this will allow us to sort of design better trials looking at anemia from knowing what each part of the country, what each centre has as their background rate of anemia. And everyone's going to be going on about this, but anemia has an effect on patient outcomes that's been shown in non-cardiac surgery and in cardiac surgery. And if you look across the country at these 20,000 patients, you're nearly twice as likely to get a blood transfusion if you're anemic before you start. That's obvious. The lower you start, the more likely you are to get blood at some point. The surgeon's going to spill a bit of blood, the bypass machine's going to hemodilate you, so that's obvious. But what's also perhaps not quite as obvious is that you spend 2 days longer in hospital and a day longer on the ICU, and your mortality is doubled. So anemic patients, I'm not saying it's causality, but association, twice as likely to die, spend 2 days longer in hospital, twice as likely to have a blood transfusion. So that's a very simple message to take home. A third of our patients are anemic, and these are so when you're designing a business plan for sort of management of anemia, we're going to talk about iron, we're going to talk about pre-optimization. These are really good data to take back to your manager and say, this is potentially what we can affect. So I'm going to look at why it's such a problem and what the pathogenesis of anemia has to do. And all I can say to you is in the UK and in Europe, we have an increasingly older society. We're all getting older, we know that, but all our parents and the generation above us are living longer, and they have more comorbidities. They're taking more drugs, more antiplatelet drugs. We were just discussing that. More drugs across the board. They're consuming more healthcare. Healthcare is becoming more expensive, not just because we've got more people in the UK, but also because each patient is consuming more healthcare. And what we have is basically an epidemic of anemia. As we get older, as we get sicker, as we have more comorbidities and take more drugs, we have more anemia. And this has been shown by various sort of international bodies, including the WHO, that as the population demographics are changing in the UK, Europe, and most of the Western world, there is an epidemic of anemia. It's increasing in propensity. And it increases as we get older. So if you look in my age group, I'm still in the 17 to 49 group, which is a nice broad group. I've got only a 1.5% chance of being anemic. But soon I'm going to cross into the 50 to 64 group, and I will have a 4% chance of being anemic. By the time I'm 75, I'm going to be at 15%. But of course, if I have cardiac disease and I have cardiac surgery, I've also already told you that it's a third. So if you're in the general population, you don't have cardiac disease, your incidence of anemia is half of what it is if you have cardiac disease. So there's something about cardiac disease that makes anemia much more likely than the general population. So I've told you the incidence of anemia increases with age, and this is a WHO study. The older you are, the more likely you are to be anemic. Why? Is it because we don't eat well when we get older? Our diet is bad? We're not fit? Well, that's what generally people used to think. This is the traditional diagnosis of anemia. When I went to medical school, this is what they taught us, that a third of anemia is caused by bad diet, nutrient deficiency, and 2/3 of anemia is caused by chronic disease or unknown causes. So there's this big group of 20% of unknown causes, 30% of chronic disease, 10% of renal failure. So basically, when I was at medical school, this was the categorization of anemia. A third nutritional deficiency, 2/3 unknown, basically. But we now know that this is a lot more to do with iron than we ever did before. We have a lot of iron in our body, 3 or 4 grams, but our turnover is very little. We only turn over about 1 to 2 milligrams a day. We lose some from our intestines, we lose some in sweat, a little bit of blood loss in women, and bladder and skin desquamation, bits falling off us. We lose some iron from that, so we only need a very small amount. But so we store a lot of iron in our body. Oops. Sorry. And we absorb our iron from our diet, and we export it into the blood with ferroportin, and transferrin transports it around between where we store it and where we utilize it. So transferrin is the important thing. But the central regulator of all this is hepcidin. Now again, when I went to medical school, we didn't know anything about hepcidin. But now we do know that it's a small amino acid peptide produced in the liver. It binds to ferroportin and blocks it. So the more hepcidin you have, the more ferroportin is blocked, and therefore it doesn't carry the iron around. So it doesn't allow the iron to be utilized to make your red cells. So as soon as you have increased hepcidin, as soon as you block it, you can't utilize all that iron you have in your body. So it's not the fact that you don't have enough in your diet, it's that it's not transported around from your stores to your utilization sites. So hepcidin is induced if you have too much iron. That's obvious. You have too much, therefore you block it being around. But it's also an inflammatory process. So as you have chronic inflammation, chronic disease, and anything going on, you produce hepcidin. And as you get older, you have increased hepcidin. So aging is basically a pro-inflammatory state. As we're all getting older, we're all becoming more inflamed, and that's the pathogenesis of atherosclerosis. Of all the diseases that we have, of hypertension, our hepcidin goes up. So as we develop disease, as our disease burden increases, be it cardiac disease or renal disease or any disease that we have, our hepcidin increases incrementally, and that stops our iron being moved around and being utilized. So that we stop making iron-rich red cells because we're unable to transport the iron, we're unable to utilize it because of this protein. So this is the problem. So hepcidin goes up due to inflammation, and it leads to this iron restriction erythropoiesis. So we now know that anemia of chronic disease is not just anemia of chronic disease, it's increased hepcidin leading to iron restriction. So you get these thin, hypochromic, iron depleted red cells, and that's the cause of anemia of chronic disease because of inflammation, chronic disease, and hepcidin. So we know the pathogenesis behind iron restriction now, and we know that anemia of chronic disease is the same as these two terms. So these can be all interchangeable now. So instead of using the term anemia of chronic disease, which is a broad term and doesn't help us with management, what we should be using is one of these two terms, either iron restriction or functional iron deficiency. In other words, we have enough iron in our body, but we're not able to use it. It's restricted because of the hepcidin. And that's the key to it in terms of management. We want to know which patients are iron restricted, which can't make their red cells, and therefore we can then go on to treat them. So we looked at a cohort of cardiac surgical patients to decide which were the causes in this sort of modern era. We looked at all the literature beforehand, and there was nothing going back many years as to what patients, what causes for anemia. So we looked at 200 patients, and we did every single blood test known to man. We asked our haematologists to dream up new blood tests and old blood tests, and we did the lot. You name it, we did it. And we also took a piece of some bone marrow from the sternum when the surgeons opened the chest so that we could stain it and look at iron staining. So we used that as our gold standard, how much iron is in the bone marrow. And then we looked at transferrin, soluble transferrin receptors, etc., 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 to work out exactly what was going on in this cohort of patients. And then we also looked at outcomes. We looked at all outcomes, kidneys, death, and our primary outcome was days alive and out of hospital. So days alive and out of hospital is, if you die on day 2, your days alive and out of hospital is 2. If you survive and you go home on day 6, then your days alive and out of hospital is 30 minus 6 is 24. So the higher number, the better. And if you go home on day 6, but you're readmitted on day 10 for 10 days, then your days alive and out of hospital is 30 minus 6 minus 10, so it's 14. So the higher the number, the quicker you go home, and it's affected by survival and admission and readmission. So it's a composite outcome, which has been well validated in cardiac disease because the burden of readmission is important. And we looked at our patients and we divided them into different groups. And the one thing we divided them into was by Hepcidin. So 20 is the cutoff value that we used, and that was our median. And that's also what the laboratory value suggests is a normal range, less than 20. And we looked at those that had a low hepcidin and those that had a high hepcidin. And the patients were somewhat different. Those that had a high hepcidin, as you'd expect, had a higher burden of disease. They were more likely to have renal failure. They were more likely to have a higher risk for surgery. That's because they had more chronic inflammation and a higher hepcidin. So it's not surprising that they had a higher burden of disease. And then from all our tests, we decided what were the causes. So we found that only 6% of our patients had iron deficiency. So traditional iron deficiency in cardiac surgery patients, certainly in East Anglia, is only 6%. And then about 10% had vitamin B12 and folate deficiency. So in fact, nutrient deficiencies together is only 16%. So I told you at the beginning it was a third. That's data from 20 years ago. Actually, up-to-date data is only 15%. So nutrient deficiencies is even less. And you'd expect that because as diet and as education improves, we should have less nutrient deficiencies. So actually, nutrient deficiencies is not the problem in our general population. There's some renal failure, with some anemia of renal failure with a low EPO and a low hepcidin. We found 10 patients with some hematological disease in their bone marrow. So early myelodysplasia, chronic leukemias, and in fact the hematologists got very excited about those patients and they're following them up over a period of time, which shows that anemia can be caused by early hematological disease, which is very important to those 10 patients because they were shocked to be told that they might have some sort of earlier myelodysplasia, but it's quite good in that they can get followed up and managed appropriately by the hematologists. But then we had over half of our patients had this anemia of chronic disease, iron restriction, relative iron deficiency that I've talked about. So this is the biggest single cause in our cardiac surgical patients is iron restriction. So iron restriction, this functional iron deficiency accounted for nearly 50% of our patients. So we subdivided those into functional iron deficiency and non-functional iron deficiency, iron restriction or non-iron restriction. And we looked at the differences between those patients, and again, they're relatively similar. The major differences were in terms of hematological tests. What we wanted to do is to try and work out the best way of identifying them. And the hematologists tell us that the best way of identifying them in a simple, cheap, quick test is what's called low hemoglobin density. And I'll just talk about that in a minute. But what it enables you to do is to see those thin, measly red cells which haven't got enough iron in them because the iron has been restricted. And if you have more than 4% of your red cells as thin, measly, feeble red cells, then you've got iron restriction. So that's the haematologist cutoff in the British Committee for Standards in Haematology guidelines for iron restriction. So in different countries in Europe, they use different things. Some people use a ferritin of less than 100 and a transferrin SATs of less than 20. But in the UK, our haematologists tell us the cutoff should be this low hemoglobin density of 4%. So finally, we looked at outcomes. Which of those states of disease were most associated with outcomes? So we found that Euroscore patient risk was the most important determinant of outcome. So it proves the first rule of the house of God, which is the patient is the one with the disease. The sicker the patient, the more likely you are to die. That's obvious. And it sort of proves Euroscore. It's been proven 1 million times, so we don't need to prove Euroscore again. We found that blood transfusion was significantly associated with outcomes. Again, that's been shown again and again and again by some people in this room. And again, I don't need to talk to you about that. None of the other hematological tests were associated with outcome. So ferritin, low hemoglobin density, all the other tests were not. But the one hematological test that was associated with outcome was Hepcidin. So if you had an elevated Hepcidin, your days alive and out of hospital was less. So for every 10 jump, you had a days alive and out, a difference of 2 days alive and out of hospital. Now you'd say that's obvious because you have a higher burden of disease, you have higher chronic inflammation, you're more at risk, therefore it's obvious that that's going to be associated with outcome. But that's important to to try and find out which of our anemic patients we should be targeting, because if they have a higher Hepcidin, maybe those are the ones we should be targeting rather than basing it on ferritin or all those other markers. That if you target the most at-risk patients, those are the ones where you're going to get the best benefit. So this was an interesting finding that we weren't necessarily expecting. So we know this. Euroscore's strongest association, predictor of outcome. Transfusion is also associated with worst outcome, and the only other thing we found was Hepcidin is predictive of outcome, independently in multivariate analysis. Okay, so half of our patients had a high Hepcidin. Half were iron restricted, but the half that had a high Hepcidin are not the same. So if you treat iron restriction, you're not necessarily treating patients who have an elevated Hepcidin. So when you're developing your sort of treatment protocol, it's focusing on outcomes is not necessarily going to be the same as focusing on causality. And that's interesting when you're designing a trial looking at anemic patients. So if you design a trial, should you design it based on a biochemical marker, or should you design it based on causality, or just design it across all patients? So this is something that we're currently discussing into which anemic patients we should be targeting. And is Hepcidin the important biochemical marker? Well, in research terms, people are developing anti-Hepcidin antibodies, anti-Hepcidin isomers, and they're now in phase 1 trials testing, looking at targeting Hepcidin specifically. So maybe in 10 years' time, we're not going to be using iron, we're going to be using treatments specifically aimed at Hepcidin. But it's very early days. They've been given to animals, and they're just being given to humans now. And of course, it may be that the more specific drug treatment gets, actually the less of an effect it has. There's some nice stories on sepsis and APC inhibitors that have never been as successful as they were thought to be, because perhaps they're more too specific in the pathway. But certainly in research terms, in university teams are looking specifically at 5 or 6 different molecules that target Hepcidin. So the story may change over the next 5 to 10 years. So what does this mean for you? How can you define functional iron deficiency? Well, there's 2 ways. In the UK, it's low hemoglobin density. In Europe, it's ferritin less than 100 and TSATs less than 20%. But these may be affected by your burden of illness, which is why in the UK they've gone for low hemoglobin density. And this is a derived thing. Your standard full blood count machine does a low hemoglobin density. All you need to do is switch it on, and it will print that out on your report. It will say HB 120, LHD 4.6%. Boom, you've got iron restriction there. And that's free. It doesn't cost you anything. It takes 5 minutes. So your standard cool-to counter, whether it's a Siemens or a Beckman or any of the manufacturers now, If the engineer comes, he pushes a switch and it gives you a low hemoglobin density. So it's actually very easy to get hold of, which is why the haematologists in the UK have gone for it, because it doesn't involve a big battery of tests. So I'm going to finish by saying this is an out-of-date classification. This is haematology, renal, B12, anemia, chronic disease, thyroid disease. Actually, perhaps the classification we should be using is, are you functionally iron deficient or not? Because that enables you to go for treatment based on whether you're iron restricted or not. And we're going to be talking about iron and about treatment. And I can tell you that 50% of your cardiac surgical patients have got a functional iron deficiency. And it's associated with an elevated hepcidin, which is associated with worse outcome. Thank you.